1.
Bore da a croeso I cyfarfod bwrdd iechyd Prifysgol Cwm Tap Morgannwg. Hoffwn I estyn croeso cynnes I bawb sy'n gwylio heddiw. Good morning and welcome to the bi-monthly meeting of Cwm Tap Morgannwg University Health Board, which is held in public. We are broadcasting today's meeting of the board live, providing the opportunity for anyone with internet access to observe in real time using a link that was shared via various channels prior to the meeting. I'd like to therefore extend a welcome to all who may be observing the meeting today. A copy of the video of the meeting will also be available following the meeting on our website for anyone who wishes to view it. In relation to today's proceedings, I'd like to note the following. Colleagues will be aware that we continue our commitment to ensure we conduct all board business in an open and transparent way. Live streaming our board meetings has been well received and allows real-time access to all of our stakeholders to observe over the internet. So as we continue to provide this facility, we are keen to return to face-to-face meetings of our board. We therefore continue to explore opportunities to enable us to achieve face-to-face meetings, whilst enabling some remote contributions through Teams and live streaming. For those observing, firstly, various of the reports being received today have previously been scrutinised by the board's committees in the weeks leading up to the board meeting. An example of this would be the Integrated Performance Dashboard report, with relevant aspects of that report being scrutinised at CTM's Quality and Safety Committee and CTM's Planning, Performance and Finance Committee. The scrutiny afforded by board committees is set out in highlight reports prepared for each board meeting, which are listed under our consent agenda items. Secondly, you may notice that board members and other presenters may not always be looking at the camera. This is due to colleagues needing to reference their board papers throughout the meeting. Thirdly, we'll be taking a very short break during the meeting after about an hour to around 11 o'clock and possibly again at 12 o'clock, depending on timings. For board members, firstly, questions on the consent agenda items have been sought in advance of the meeting. I can confirm that no questions have been raised in advance of the meeting. Secondly, as referenced earlier in my introduction, where it is evident reports have received significant scrutiny at board committees, the board will take this into account when receiving this item and therefore the amount of time focused upon it. Thirdly, as part of the steps we take to seek to continue to improve the work of the board, at the end of today's meeting, I will be asking colleagues how you think we have done. There are some question prompts set out in regard at the end of the agenda. I encourage all board members to keep this in mind and offer reflections and suggestions in this regard. All board committee chairs have adopted the same approach after each committee meeting. For presenters, when introducing a report or giving a presentation, presenters need to take into account that board members will have read the reports in advance of the meeting, and hence the board will only need to be made aware of any issues that may have changed since the report was drafted. I'd like to welcome Christopher Waters, Frailty and Chronic Conditions Nurse, and Melissa Duffy, Frailty and Chronic Conditions Nurse, to the meeting. Chris and Melissa are both here to present the patient storage agenda item 2.1. Sally Davis, Deputy Medical Director. Sally is attending on behalf of Dom Herbert, Medical Director, who has tendered his apologies. Debbie Benyon, Deputy Nurse Director. Debbie is attending the meeting on behalf of Greg Dix, Executive Director of Nursing, who has tendered his apologies. Sally Bolt, Associate Member of the Board and Chair of the Cwm Tap Morgannwg Clinical Advisory Group. Stephanie Muir, Assistant Director of Concerns and Claims. Suzanne Hardacre, Director of Midwifery, who will be attending at the end of the meeting to present the Maternity and Neonates Improvement Programme report. I would also like to advise members that this will be Kelechi Nohan's last meeting of the board before he departs the Health Board at the end of November to undertake a new role in the private sector. I'd like to thank Kelechi for all the support he has provided to the board over the years, and I'd like to wish him all the very best for the future. I would also like to take this opportunity to record my personal thanks to Georgina Galatli, who until recently was CTM's Director of Corporate Governance and Board Secretary. Georgina has since joined Welsh Government's Executive Implementation Programme team. We are very grateful for her leadership and commitment to improving our governance arrangements and wish Georgina well in her new role. I'd like to advise members that following the end of the public meeting, we'll be holding a brief in-committee session to discuss core participant status for Module 3 of the COVID-19 inquiry. 1.2, apologies for absence. But apologies from Greg Dix, Executive Director of Nursing, Dom Herford, Executive Medical Director, and Lauren Edwards, Executive Director of Therapies and Health Sciences. With respect to declarations of interest, Caroline Donoghue, independent member, has declared an interest in relation to agenda item 5.2, Board Assurance Framework, advising that she is chair of the Welsh Wound Innovation Centre, which is referenced within the report. Does anyone else have anything they wish to declare an interest at this point? Wendy, can you confirm if there are any interest, please?
There are none declared, Chair.
Thank you. We will then go on to item 2.1, which is the patient story. I'm pleased to invite Christopher Waters and Melissa Duffy, frailty and chronic conditions nurses, to present today's patient story. I invite Chris and Melissa to say a few words before they share a presentation of the work being undertaken by the Frailty Service. Christopher and Melissa, please.
Hello, thank you for having us today. So we've prepared our presentation for you, which is on the screen now, yes, yeah. So we've been in operation now for what will be 2 years in March. It's a very proactive service. I'm just having problems with my sound a sec. We were set up 2 years ago now, come March. We were set up in the heat of the pandemic, so we've proactively been contacting our patients. With that, when we started, obviously with COVID, a lot of patients that we contacted were saying this was the first health professional contact they've had, you know, since 2 years with during the pandemic. Obviously, there were high levels of isolation and deconditioning, and our aim of our service was to contact people and keep them as well as possible. If I could go on to the next slide. So the principles of our practice, we get GP referrals for patients that perhaps they're finding aren't engaging too well and need that extra bit of time and continuity. We use case findings, so we have run lists of GP lists of the system for patients with potential frailty triggers and haven't had any contact with individuals for a few months. So we utilise the electronic frailty index to clarify the sort of need and appropriateness for contact. Our assessment templates are basically led by the person, what matters most to them. Principles of the comprehensive geriatric assessment and sort of anticipatory care planning. And for us, the long-term follow-up is really important to sort of build trust with individuals and to offer sort of not traditional reactive approaches to care. So to sort of flip the model on its head, contact people whilst they're well, give them the information, and quite often it's a kind of follow-up home visits or telephone calls where we're able to engage better in care planning. And it's also about sort of looking at the person as a whole, providing holistic assessment, and moving on from there. So next slide, please.
Thank you. So as a service, we are two people covering the Taffili area. It's a large area to cover with large numbers of clients that are open. Oh, sorry.
We're just going to reload the presentation, Chair. We're just having a few technical issues, so bear with us.
Okay, thank you, Kelly.
Thank you very much. So, sorry, back to the beginning of the slide. We're 2 people covering the Taff Ely area. That's the right one. Thank you. Sorry, next slide again. Thank you. Optimising information technology. So we know as 2 people covering the areas, technology is now and technology is going to be, as always, our future in supporting healthcare out there. We therefore work remotely. We're able to refer, assess, review and input data at our fingertips whilst we're with the patient, whether that's in their own homes or in a community setting. We are then, whilst with them, able to identify and input into our templates to make sure our communications to both secondary and primary services are updated and input via patient records. We're able to make any information and decisions, doing assessments and calculate needs there and then, as well as the previous anticipated needs we've had during our case finding. We've been able to support GPs and support data across the health board and primary care because of the high quality read-coded data that we're providing through our templates that we've developed across the systems. And we're also working actively in improving and supporting our service across the health board and within primary care from active feedback that we are gaining from patients via Civica and through collecting information via patient stories. Next slide, please. So as we went and completed some case finding to identify individuals across the services, we worked with GP practices for internal referrals, and we found that by the time the referrals reaching us, patients already had input from other services, and working in a proactive manner, the need was already too late to identify. So we stepped it up a level and we went out into the community areas. We attended community service, local services, coffee mornings, community events, community centres where we've got community people bringing groups and helping with social isolation and bringing people from those communities following COVID who haven't had any input or support from anybody for a long time back into the networks. Again, the same principle applies. We've got our information technology, our computers, our devices and anything that we need there with us. So we're able to give them first-hand information and it's instant for them if they need referral on or support. So we know reports out there from the Welsh Government are wanting to flip the nursing model on its head. Like Chris had already said, we want to reiterate that message. We're speaking to people while they're well. We want to link back in with them at a later date and know that they are keeping well. We want to give people the education, we want to empower them, we want to give them the information to know who to call and when to call and where to call. We want to be able to make sure they're having every contact count, getting information and getting care from the right place at the right time. In the areas that we work, we can identify that there's different deprivations and there's different clients that have access to different facilities. So we want to be able to build those bridges and make sure that people are aware of all the different access and the facilities that's out there for them. Next slide, please. So here we've got a bit of a demonstration of the amounts of people that we have been reaching through the last 12 months of the project, the interventions that we've been supporting them with, and the referrals onwards that we have been making. So we would find that some clients would contact the GP for everything, regardless of whether there was a GP need. And we've got other clients out there who may not want to reach out to anybody, and they would only attend an A&E department when they're in a matter of crisis. So from our numbers over the last rolling 12 months across the Taff Ely area, we have reached out to 610 people across the area. Each of them people have a knock-on effect, whether they have support from a carer, family or other inputs that we're trying to support as well. And then the different interventions that we can support. It doesn't just have to be healthcare. We are linking in with our third sectors and we are linking in with social care as well, because we appreciate that a lot of issues that people have don't just come from a healthcare need. So we need to work outside of that box and link everybody in with where they need to go.
So like this assessment and sort of interventions have been almost ad hoc and opportunistic. So talking about advanced care planning at the very earliest stage, you know, rather than waiting for somebody to present to a reactive service, being preventative as much as we can. So move on to the next slide, please. Okay, so the reason we've come here today, we were initially asked to provide a carer's story, which we've done. During this kind of approach, the actual patient wanted to be involved as well, who's kind of just received a diagnosis of dementia, you know, as a result of our sort of referrals and follow on. So we're going to call them Mr. and Mrs. Jones just for the purpose of this presentation. So we did a proactive case find, found Mr. Jones who had quite a high level of symptom burden and sort of triggers on the electronic frailty index. He hadn't had any contact with health professionals in quite some time, so we gave him a call. Initially, he didn't really feel that there was anything that he needed. However, his wife had other ideas. Mrs. Jones was identified as a carer, so she was providing sort of prompting for every activity daily of living for him. He was having a lot of day and night disturbance, so she was promoting orientation quite frequently. So, you know, it was identified that they were both concerned about Mr. Jones's memory. He completed a cognitive screen, liaised with a GP to do sort of blood tests and CT scans, and I referred on to the memory assessment service. Physically, Mr. Jones was falling. Just some baseline observations noted that he had a very low heart rate and he was still on medication to kind of control that, that was perhaps causing him to fall. Mrs. Jones, you know, was concerned about how she would manage in the future should anything happen to her. What would happen to Mr. Jones? We referred to social services to get some contingency planning in place. She was worried about planning for the future, so I helped her with an advanced care plan with that. Ensured she had a carer's assessment to make sure that there was a plan in place if she was unwell, you know, the sort of emergency card scheme for that. And then ensured that she had access to the sort of appropriate allowances and benefits to support her caring role. And also, you know, we looked at care and repair to sort of, there were sort of various home modifications, simple modifications that could help them remain as independent as possible. Next slide, please.
So here we have the summary and some of the comments that were made from both the patient and the carer during the patient story process. It was completed within their own home, within their own environment, so they felt comfortable in making any conversation or making any comments that they wanted to give to us. So we covered areas and the themes that we picked out from the comments of positive proactive engagement, whereby from a carer's perspective, Mrs. Jones had felt that she'd received a cold call as an aspect of case finding, and she was a little worried that she didn't maybe understand what the husband may have told them on the phone because she wasn't there when the call happened and didn't know what the outcome was going to be. However, part of our process, we follow up with written information, and Mrs. Jones felt that even though her husband had the cold call, didn't make a note of it, didn't remember much of it, didn't feel he needed anything, when she received that written information, they were able to have an open conversation with each other, looking at some of the information that was provided. There was different contact details on it for different services. They were a little overwhelmed that they didn't know how to coordinate it, so they were able to contact us direct, and they felt very relieved that we were able to support them in that process in linking in with these different services. We were able to complete information with regards to continuity from them, so they felt that it was ease of access for them to be able to contact us. They felt relieved that if they knew that they needed a follow-up with information, there was continuity there, it would be the same person, and how they were able to link in with us and the information that was provided and the referrals that were completed. One of the comments that Mr. Jones had made was his initial aspect and thoughts on it was he'd had a stroke and he didn't think that there was anything more that could be done for him to a point where he was quite happy that he would just sit there and he would have nothing else to carry on doing, just sit in his own house, and when things went wrong he would call for help. They expressed situations where previously they hadn't received much information or didn't know who to go and when to call people if there was problems, and from having input with us they'd fed back that they are now getting information that they'd never received before their contact with us as a service. Next slide please. So again, some follow-on themes about the service and how they felt that it was to them personable, and they were able to familiarise themselves with each of us and what was provided to them. They stated that any issues that they'd raised and any information that they needed, if a referral was to be made, they had to follow up, they had the information and the communication behind it. And I think one of the outstanding comments that they made was that without the service they would have continued to have plodded along. They now have a better understanding of what support is available to them and how they're able to manage their problems. And they stated that being supported and being able to be as independent and safe as possible at this age was a blessing to them, and they were quite open in that they'd looked at other people around them and felt that the information and access that they were having and the service that they were being provided with was maintaining their independence and remaining at home and being safe together. Some of the information that we received from the patient story, it was giving us reassurance that some of the processes that we were doing in calling people and following up that information with written information gave us positive feedback, because we was a little bit worried about the amount of people that we may need to contact via written information, but we need to be mindful in the different clients that we are working for. They need to be able to have the information to hand, whether they want to make a decision on things there and then, or if they want to think about it and come back later.
Can I just check where we are in respect to the presentation, please?
We appear to have lost our presenters there, Chair.
Okay. Can I just say, I suppose, where we're at the moment is that thank you to Chris and Melissa for sharing this presentation on the positive work that they're doing as chronic condition nurses. I'm conscious that we may not have the opportunity to ask either. Sorry, Karen?
Yes, we have them back now, Chair.
Okay, if we could invite them back in again then, please.
Sorry about that.
Sorry.
Can we go to the next slide? Okay. Sorry, last slide anyway, but you know, I think from what we kind of demonstrated, gathering feedback from patients, and also the sort of everything we input into the system is auditable. So we've been able to have proactive engagement, identify patient needs much earlier. You know, a lot of our referrals onwards involvement, we've facilitated, you know, contact into rehabilitation, so tackling that sort of deconditioning. Patients have really reported back to us and via the sort of, you know, Civica survey that, you know, we've provided continuity, and they don't want this one-stop assessment or half an hour in a clinic setting, or, you know, in a GP surgery. We're able to provide that sort of longer term follow-up and allow them to process a lot of the information. The quality data, so the data that's been inputted, because our assessment templates are read coded, you know, every patient's the EFI score went up, and, you know, we were able to sort of monitor what we were doing much more closely. We've provided advanced care planning at a very early stage, and I think, you know, moving forward, we are working with the values-based healthcare team. We're now doing a fuel poverty project with public health and the segmentation team. So moving forward, you know, we'll be utilising a system that's much more sophisticated at identifying patients that are high at risk of attending A&E or declining. So it's really exciting work moving forward. This is the case finding in the chart that we've managed to do so far. There's much more that we can do. We see why this really couldn't work in any other area across CTM, and perhaps even more areas of deprivation. So, you know, I think moving forward, having that support from public health and utilising the systems that are now available to us,
it's much more effective and efficient, and it gives us more time to be out there doing the assessments rather than scrolling all of the information to identify who is at need.
And we see no reason as well, and what we've demonstrated, you know, even if we were moving forward for sustainability, to just contact every person over the 85 category and you know, ask them what matters to them, what can we do to sort of improve their health and well-being. Thank you for listening.
Okay, thank you for your presentation. If I just invite members to raise any questions in respect to the presentation, and if I could invite Kelechi Nohan, please.
Thank you very much, Chair, and thanks so much, Melissa and Chris, for that presentation. I think just listening to that presentation was really, it's like music to my ears, because and you reflected that latterly about making the connection with the segmentation data that we now have. And this is really important, because when we set out that population health management segmentation work, it was always that recognition that there are two parts to it. There is the using all of the artificial intelligence and machine learning and all of the analysis to analyze our integrated data on our population and then identify the needs of our population. But the genius of population health management really happens with the work you guys are doing, taking all of that intelligence and then linking it to how you change the shape of care and put our care on a more preemptive, preventative and anticipatory footing. So I'm really delighted to see it come together. So this is the blueprint for what CTM should be doing for our population going forward. But you know, thank you, and thanks for telling that patient story, because at the end of the day, this is about how we change the lives of people on ground and make it better. But excellent piece of work. Thank you very much. And for me, for CTM, our question has got to be, how do we give this scale? How do we make this the way we function and the way we work? Because that's where we need to get to. But thank you, really enjoyed it.
Thank you very much, Kelechi. I do have to say, we have attended an event in the past where you discussed quite a lot about the link between individuals' poverty and how they're living and how it affects their health. And I think you gave an example of the returning patient with COPD and the exacerbations. And I feel that that is where we've got a really large part to play, because we can feed into secondary services and give them that information of how those people live and cope at home. Like Chris said about the half-hour clinic and consultation, we feed the bigger picture around it.
Brilliant. Thank you, Melissa.
Thank you, Kelechi. If I could invite Paul Mears in, please.
Thanks, Emrys. Yeah, like Kelechi, really great to hear the case study you gave there, and also understand more about the broader service you're providing. And I guess just really, as Kelechi was saying, it's really opportune that we're having this presentation at the board, because we're just going through the process as an organisation of looking at what the model of out-of-hospital care needs to look like for the future, because I think we'd all acknowledge we've got some fantastic examples already in CTM, and these guys are just one of those examples. But I think if we're honest, we've also got lots of examples of where we've got pockets of really great practice that we want to try and spread more broadly and make it a consistent service, because you guys are obviously working in one locality, and we want to make sure that this approach is rolled out more broadly across a broader locality. So I guess there's something for me, question really to colleagues about what are the things that perhaps are the barriers or that you might have sort of wanted to try and or what are the things that are perhaps stopping you, get in the way of you doing even more with the model. And I'm just thinking particularly around the opportunities perhaps for greater levels of coordination with social services and other colleagues like that, because many of the patients you'll be dealing with have multiple needs, don't they? That aren't just health, they're also social care, they might be housing, they might be, you know, other services. So I guess a question really for you about what are the barriers you think are there at the moment, and that what can we do to support, I guess, trying to address some of those.
So I think the biggest thing for us at the moment is we are only 2 people. I don't think that it doesn't matter how much of a pathway or process we put in, we can still only see the amount of capacity and the amount of patients that we can see. So for us, we are trying to make direct referral processes and pathways for the likes of single point of access, social services, low vision departments, opticians and people out there, because otherwise we would spend many a day just making sure this referral's gone to that service and following up the referral processes. So we've simplified some of those. And initially, proactive working across some of the areas caused a little bit of a worry for people because we didn't know what we were going to open up. We didn't know what we were going to find. So it was just providing reassurance and making people aware that we've got processes and pathways in place, that if we do identify somebody that has been in an area of need for a long time, we can direct them to the right people, we can link in with the right places, we'll coordinate both health and social if it means that we need to have an integrated plan together. And I think like one big thing for us to learn before we went live as a service, we needed to make sure that we had the access to the templates, to the GP records, to the secondary service information, because otherwise you're going out in the dark, aren't you, and you can't provide anything further.
Thank you. If I could then invite, I'm just conscious of time, but I can invite Kelechi Noam in again, please.
Thank you, Chair. I'll be really quick. I think it's just picking up from Melissa's response to Paul's question, and I think one of the questions we keep asking ourselves as a health board is we want to be more allocatively efficient as a health board that manages, you know, £1.3 billion budget for a 450,000 population. An allocatively efficient organization would be looking where can we get the biggest bang for buck in terms of outcomes for our population. This has got to be it. So these are the areas of our spend where going forward, we should be looking to put in more investments. One of the biggest questions I always get from GPs about what to do with the population health management data is that we don't have the capacity to go after the needs of patients that we haven't identified, because we can't even respond perfectly to the need that is knocking on our doors. So we've got to shift the spend upstream and help them with services like this, go after those needs that ultimately put significant pressure on our system downstream. So I know it's something that we do have in mind, and I think as an organization, we should be looking to be allocatively efficient over time by investing in services like this.
Thank you, Kelechi. I'm just conscious of time here and coming to the end of our presentation time here. Did you want to respond to that, Chris and Melissa, before I finalise the session?
It's just reassuring to hear, really, because it is, like Kelechi said, we are worried about challenging and being able to demonstrate the future. But if we're not acting proactively now, the future is just going to carry on being reactive. So the savings and, you know, the time, the cost, the lives that we can support the here and now will be demonstrated going forward.
Okay, thank you. I know we had a few problems with the technology there, but I have to say thank you both, Chris and Melissa, for sharing a very informed presentation about the really positive work that you're doing, and it certainly reflects some of the sort of systems working that we're wanting to deliver across the whole of the health board. So thank you very much, and I'm asking board members if we could note the presentation, please. Okay, thank you again. Okay, if I could go on then to item 3, please. To ensure we focus on business critical activity and discussions, we continue to use the consent agenda for this meeting. I'd like to remind everyone that highlight reports from board committees are routinely included on the consent agenda for formal noting and are placed on the main agenda for discussion only when there are specific areas identified in the report for escalation to the board. I'd also like to remind colleagues that many of the items on both the consent and main agenda have already received significant scrutiny by our board committees prior to being put before the board today. It is important to note, therefore, that the level of discussion and debate at the meeting today is not a representation of the totality of time and consideration undertaken in relation to these issues on behalf of the board under the board's scheme of delegation to committees. Given colleagues will have had the opportunity to read all the items placed under the consent agenda in advance of this meeting, are there any issues that anyone wishes to remove to the main agenda for discussion? Wendy, can you please confirm if there are any colleagues raising any questions or any objections raised to any items in the consent agenda, please?
There are not, Chair.
Thank you. I therefore propose that all members present are happy to approve and note all items as requested. Then go on to the next item, please, which is the Chief Exec's report, please. I invite Paul Mears to highlight the main items to report, which is for noting.
Thank you, Chair. Yeah, just wanted to summarise a few key things happening in the organisation. First of all, I know we've got an update later on the maternity and neonatal work, but obviously it was really positive news to hear earlier in this month that the Minister had agreed to the recommendations of the IMSOP panel to move the maternity and neonatal services out of special measures and into the TI category of escalation. I just wanted to use the opportunity to say thank you to all of the colleagues involved in maternity and neonatal services for the huge amount of work that's gone on over the past 3.5 years to get us to this point. It's been no mean feat to turn around this service from a really, really challenging position that we started with 3.5 years ago when the original report came out. There's lots of learning that's being had within the service, but I know also within the board, and we've obviously got a follow-on meeting with the IMSOP panel in terms of the learning from the process in the next few weeks. I just wanted to also thank Greg, even though he's not here, for his leadership through this process, because he's very much been instrumental in leading the improvement, and more recently Sally Davis and Suzanne Hardacre, who have really picked up and taken forward the leadership around this agenda. So thank you to both of them. In terms of the wider targeted intervention work from Welsh Government, we had the feedback from the tripartite meeting of Welsh Government, Healthcare Inspectorate Wales and Audit Wales, and the Minister and NHS Wales Chief Executive have written to myself and Emrys confirming the current escalation status, which is set out in the report. We've got further meetings planned in the next couple of weeks with Welsh Government to understand a bit more about the particular concerns around performance. Obviously, there is concern around the performance around elective recovery and particularly our cancer waiting times. There's a lot of work already underway in those areas to look at improvements. So I think particularly learning from our most recent experience of TI and escalation, I think we'll be quite keen to understand from Welsh Government what exactly the areas of concern are, what the measures for improvement need to look like, so that we're really clear and specific, because I think we all know through these processes that being clear and specific about what expectations are set from government for improvement at the beginning is really important, and avoids perhaps open-ended processes that that can lead to slightly confused expectations around what's going to lead to de-escalation. So I'm really keen that we try and get that clarity early from Welsh Government, and we'll be looking forward to meeting with them to talk that through. In terms of the leadership updates, Emrys mentioned at the beginning, George's moved to the Welsh Government team leading the transition to the new Initiative Executive, and I'd just like to add my thanks to Emrys for the significant contribution George made while she was with us as Director of Corporate Governance. And I also just wanted to add my thanks to those of Emrys for Kelechi. Kelechi's been a fantastic advocate for public health and population health across our organisation since he joined 6 years ago. But I also think we can't forget the massive contribution he's made, particularly in the past 2.5 years during the pandemic. Kelechi was front and centre of the response of CTM and indeed the local authority partners in the pandemic. And not only has he represented CTM magnificently through that period in terms of fronting up with various media interviews, radio interviews, TV interviews, but he's also represented the wider public health community in Wales and was seen as the go-to person for a public health perspective on what was going on during the pandemic. I think our approach to population health is probably one of the most advanced within Wales in the NHS, and that's down to Kelechi's leadership and drive to promote that agenda within this organisation. And I think we will really miss him and his contribution to our executive team and to the board, I know. But also he could be confident that he's leaving a legacy and a focus of the organisation that will continue after his departure into pastures new. So just really wanted to add my thanks and best wishes to Kelechi for his contribution over the time he's been with the Health Board. Finally, we've got an update later on winter planning and emergency pressure, so I'll leave that to get into update. But also just wanted to update board members on some really positive developments in terms of our relationships with colleagues in the council in Bridgend. We've had a really positive discussion with colleagues in the chief exec, the leader, the cabinet member for social services and director of social services about the opportunities to develop further levels of integration of service between health and social care in Bridgend. Many of you will know that there are already really good examples in Bridgend of joint integrated services between the Health Board and the Council. Some really positive developments over the past few years in that space. But a willingness and recognition that there's a lot more we could be doing in a more joined up way between us. And so attached to my report was a paper that was taken through to the leader, the deputy leader and cabinet member and Emrys and Jane Sagrove, our chair and vice chair, to talk about a proposition to further integrate health and social care leadership in Bridgend. And that's leading to us to agree to developing a joint head of service post across health and social services in Bridgend, and also a plan to start a more detailed programme of work on integrating health and social care in Bridgend that we would hopefully see as a model that might be able to be deployed in other parts of our patch as well with the other two local authorities. So information there in my paper that I and Mark Shepherd put together describing that approach. But I think it gives us a really significant opportunity to take forward to the next level the opportunity to integrate health and social services support for adults in Bridgend. I think that's particularly pertinent given some of the challenges we're all facing in terms of workforce, and indeed some of the reflections from colleagues in the previous presentation about the need to provide a more joined up service to our communities, particularly those with most vulnerable and need of most support. The more we can bring together health and social care into one place under shared leadership, the greater the opportunity to make sure those individuals get a much more coordinated and joined up response, but also that we're making best use of the collective resources available to us across health and local authorities around this agenda. So really positive step forwards there with Bridgend, and we'll obviously be giving further updates to the board as we go forward on that. Other point to raise is the development of the conversations in MySteg around the future model of care that we want to provide in MySteg and what that will mean for the development of the community hospital site there. There's been some really positive engagement over the past month with elected members from the council, the MS, the MP and other stakeholders in MySteg, including the League of Friends, to talk about what we would like the future model of care to look like for the population in MySteg and how we can develop services on hospital sites to respond to that. Really positive engagement from those stakeholders and a willingness to be involved in those conversations, and really pleasing to see now a plan for engagement events in MySteg over the next couple of months where we will be going out into the communities, involving voluntary sector groups, community groups, elected representatives in a conversation about what we can do to develop the hospital site to respond to particular needs of that community, particularly given its location, some of the deprivation issues there are in that area. The opportunity to develop a more provision of services locally to that community, I think, gives a really great opportunity to respond to the population health needs of MySteg. So really great that is being taken forward and being done in partnership with stakeholders and also the local authority. Also, just to update that we had a very positive report, as members will know, about the Emergency Department HIW inspection of the Emergency Department at Princess of Wales. Really, really great feedback considering the pressure that the services are under at POW. So positive feedback there, and that was all I wanted to highlight really from my report, Chair.
Thank you, Paul. I invite members to raise any questions. Are there any questions for Paul's report, please?
There are none, Chair.
Thank you. Thanks to Paul for presenting the report. Unless there are any objections, I suggest the board resolves to note the report. If we go on to item 5.2, the Board Assurance Framework. I invite Callie Hamblin to present the Board Assurance Framework update report, which was received by the Executive Leadership Group on the 7th of November 2022 and is before the board for approval. Callie.
Thank you, Chair. Thank you for allowing me to present the November review of the Board Assurance Framework. I'll take the report as read, so I only just want to draw board members' attention to the specific changes and actions that were taken during this period. Those are outlined in section 3.3 on page 3 of this item. So the main changes in terms of review were relating to strategic risk 3 and 5, and you also note that I added a update in the cover paper that our Director of Finance is also looking at whether there should be a separate strategic risk around capital resources. So that's an emerging one that may come through in further iterations of the Board Assurance Framework. Just for transparency, I just want to reassure members that although we don't now receive the entire organisational risk register at board, it is available in admin control and of course still received at our board committees as appropriate. Those are the main points I wanted to pull out of the Board Assurance Framework, Chair. So unless anyone has any questions, which I'll look to my executive colleagues for answers to as the strategic leads, that's all I wanted to update on. So thank you, Chair.
Thank you, Callie. I invite board members to raise any questions. If I could invite Ian Wells in, please.
Yeah, thanks, Emrys, and thanks, Callie. Quick question, I think it is anyway. Great to see the risk reduction on risk number 5. I'm not quite clear from reading the text, however, as to the rationale behind that. It says in the thing that it's been embraced in the community, but that's a little bit vague. I wonder if there could be some examples given as to what. And I did look further down as well, and I couldn't really see what the trigger was to actually reduce that risk.
Thank you, Ian. Thank you, Chair. Perhaps I could bring our Kelechi Nolan in as our Exec Director of Public Health, who's the strategic risk owner on that one, just to provide a bit more of an update. So Kelechi, could I ask you to respond on that one? It's strategic risk 5, community and partner engagement.
Okay, thank you very much, Ian. Thanks for raising the question. I think this is one of the ones that we will always need to keep working on. But the key reason why we adjusted that risk in the direction that we have is that you may be aware that recently the PSB, that's the Public Services Board, as well as the Regional Partnership Board, completed a very comprehensive population and well-being assessments for CTM. And they actually conducted those risks as individual partnerships, but there was incredible coordination. And as you know, the Health Board is an active partner in that space with all of our other services, public services in that space. So I think that's a very, very important piece of work to have completed in terms of our engagements in the partnership space. Now, obviously, it creates new challenges for us because once you know the needs of the population, then the question obviously is, what are you going to do about it? Now, in generating our intelligence about the needs of the population and in working together, partnership is obviously very important. So, but I think it moves us forward. If it doesn't necessarily answer all of our questions, but I think it moves us forward in terms of strengthening our partnership and CTM's role in that partnership space. And I think it was on the basis of those completed partnership needs assessments that we adjusted that risk.
Thanks, Kelechi. Is it therefore a good idea, and I don't know, Carly can give advice on this, to actually say what you just said in brief and what the trigger was? Because when I see a risk reduction, I want to see what the trigger was to actually cause that. only needs to be a couple of words, doesn't it?
Yes, yes, thank you. We'll take that very much on board, Ian. Thank you.
Yeah, thank you.
Okay. Thank you, Kelechi. Thank you, Ian. If I could then invite Patsy in, please.
Thank you, Chair. Just a quick question, really. I think congratulations to the team who are in order here, because this BAF is continually improving and is very informative. We do need to take care not to let it become a dumping ground for everything that's going on within the organisation. So there are a couple of things in there, like business continuity planning. We have to do business continuity planning regardless of the strategic goals. So it mustn't grow exponentially, because then it will become too long and rambling and people won't necessarily read it all. Just specifically on the finance, completely agree with the change of consequence and impact. Is kept the same score, but it's moved those two things around. And there's a good explanation of why that's happened. On the detail of that, when you look beyond that initial page, risk 3 details, there's a bit of a typo in there, in that one of it reads 4 times 45, so we just need to change that. But well done to the team. I think it's improving every time we have a board meeting. Thanks.
Thank you, Patsy, and thank you for your comments there. Can I just check with Wendy, please? Are there any further comments or questions, please?
Nothing further, Chair.
Thank you. So thanks to Callie for the report. Unless there are any objections, I suggest the board resolves to approve the board assurance framework. Thank you. If I could go on to item 5.3, please, which is the Nurse Staffing Act. I invite Debbie Benyon to present the report, which is before the board for noting. Debbie.
Thank you, Chair. Thank you, Chair. Just to, in summary, this is the annual presentation, which is covering October 2021 to September 2022. And just for context, the Nurse Staffing Act, which came into being in 2016, requires the designated person, in this case, the Executive Director of Nursing, and I'm deputising for him today, to formally present to the board the nurse staffing requirements for the adult inpatient wards, medical, surgical and paediatric wards. The purpose, very briefly, is a summary of the agreed levels and changes that have occurred in the reporting period where Section 25B applies, and those are the wards I've just described. And in those wards, there's a duty for us to calculate the staffing levels by a biannual audit of activity and acuity, professional judgment, patient population, staff in post, triangulated with some care indicators, such as falls, pressure ulcers and medication errors. And the January and June audit of this year is there for detail there. It's detailed in the appendices. Just of note, Prince Charles Hospital's Ward 8 and 9, Royal Glamorgan Hospital Wards 19 and 20 have continue to have a temporary uplift in their staffing at cost pressure to support their high levels of acuity. And another note is Princess of Wales. 8 out of 11 of their wards are needing possibly an uplift into their healthcare support workers, but they've just got marginally increased acuity there. Just of note, 3.1, the other work streams related to mental health areas, etc., have been paused at the request of the Chief Nursing Officer. If I take you to 3.2 there, regarding the roster policy, just to say that that has been launched. We've launched Safe Care rollout, and both of those are allowing us to monitor our key performance indicators with much greater scrutiny and support. So our recommendations at the moment are those that I've indicated in that report, that at the moment we are not recommending any permanent changes to our establishment until we redo the audit in January. And of note, many of our wards and departments are still settling down after COVID. They're being repurposed, and they still continue to be slightly repurposed since that time. So Greg Dix and myself feel January is a better time to actually look at any permanent change to that. That was just that in brief. I'm happy to take any questions.
Thank you for that, Debbie. If I could invite Carolyn Donoghue in for the question, please.
Thank you, Chair. This is a really useful report, thank you, and it's great to see this systematic approach to ensuring that our workforce reflects the care needed. I have two questions. You mentioned the cost pressures in this sort of temporary increase in staffing, and I just wondered how we were managing that and whether you see that as ongoing, or whether that is, once you've done the January review, you'll look at how it goes. And the other question is, it mentions that there is no hostess service on a number of wards, and therefore you've got healthcare support workers carrying out that activity. And I wondered what the plan was there, because that doesn't necessarily seem to be a good use of healthcare support worker time.
Thank you very much, Carolyn, for the question. So the first question regarding whether we see this going onwards, the corporate nursing team in conjunction with our patient safety team are doing a lot of work on the wards on Prince Charles Hospital and Royal Glam, looking at enhanced levels of care. So looking at actually, are there other ways we can support our patients in mobilising in our medical management of these patients as well. So I can't actually tell you that I see this ongoing after January, but it is likely it might well do. It might well do. And that at that point, obviously, if we feel, Greg and I feel, and the wider teams feel that there needs to be a permanent uplift to support that, that will be brought to board at that time, or brought to the executives at that time. In relation to hostess services, you are quite correct. There's a disparity currently between Prince Charles and Royal Glam and Princess of Wales Hospital at the moment. So we're going to be working with our colleagues in our catering service, etc., to look at the cost effectiveness of bringing hostesses and bringing the whole health board into line with the same support there, and that then will enable us to understand whether it's more healthcare support workers we require, or actually is this better delivered by an increase in our hostess service. So that is being looked at now.
Thank you very much. And just to pick up on Howell's point there about we probably need to find a different term to hostess for that role going forward, but that's really helpful. Thank you very much.
We can do, that's fine.
Thank you, Debbie. Thank you, Carolyn. Can I just confirm, are there any further questions, please?
Nothing further, Chair.
Okay. Thanks to Debbie for the report. Unless there are any objections, I suggest the board resolves to note the report. Thank you. If I could then go on to item 5.4, which is Planning Performance and Finance Committee Highlights Report. I invite Mel Jehu to present the report, which is before the board for noting. Mel.
Yeah, thank you, Chair. This highlight report comes as a result of a planning, performance and finance meeting which took place on the 26th of October 2022, of course. And it's there just for noting, really, but there was one item which we thought as a committee we should escalate to the board for its attention, and that was the issue in relation to the report that we received in relation to the ophthalmology follow-up not booked, or as we refer as FUNBs, in relation to the ophthalmology department. There are significant challenges, as we already know, and probably the committee knows, in relation to the service and the treatment of ophthalmic issues within the health board as a result of course, of the pandemic and the backlogs, etc., and the demand. And we received an in-depth report in relation to those follow-ups not booked in relation to ophthalmology, and the actions and the mitigations being taken by our executive staff and of course our frontline staff in relation to that. But we felt it was such a significant issue that it needed to be brought to the board today, just for awareness, so that the board could be alerted to the issues. But we will of course in follow-up meetings continue to probe and to make sure that the performance is going in the right direction in relation to that. The rest of the report, as you'll see, is just on an advisory or an information basis for the board's assurance. I'm not going to go into great detail. As I said, I know the report has been read and has been circulated widely, and indeed at that last committee meeting, it really was an in-depth and vigorous meeting, which I know, Chair, you attended along with the Vice Chair, along with committee members. And I just feel if there's any questions that need to be posed, I'm here and available to try and answer. If not, I'm sure I'll have the support of the executive team who were there as well. Thank you, Chair.
Thank you, Mel. I invite board members to raise any questions. And if I could invite Jane in, please. Jane Sacco.
Thank you, Chair, and thank you, Mel. It's about ophthalmology. I just want to make a comment. As Mel has already said, I attended the PPF meeting and also I chaired the quality and safety meeting, which looks at the issue from the aspects of harm caused by delays. We have since had a further report to the quality and safety meeting, updating that committee, and we will be giving further attention to this particular issue going forward from the quality and safety perspective. And I know that PPF will also be looking at it from the performance perspective. So we hope to see some improvement going forward, given that level of scrutiny. Thank you.
Thank you, Jane. Can I confirm if there are any further questions, please, Wendy?
Yes, we have a question from Patsy Roseblade.
Okay, Patsy.
Thanks, Chair. Thanks, Mel. Just a comment really before this goes onto the website for members of the public to read. Under the finance section, there's a typo in the middle there. I think there's quite a few words missing. Just needs correcting before it goes on the website. Thanks.
Thank you for that, Patsy, and those comments will be noted. Are there any further questions? Oh, can I invite Paul Mears in, please?
Thanks, Emrys. It was just to say that, just to provide reassurance, and I know this was given at the committee about the situation around ophthalmology. It is a challenging picture we're dealing with. Gethin and colleagues in the operational teams, I know, are working hard on providing additional capacity into the ophthalmology service. I'd also say it's an area where we are working very closely with our neighbours in Aneurin Bevan and Cardiff to look at how we can use capacity that's available across the whole region to support ophthalmology. So where we may have capacity constraints, what can we do if there is capacity in neighbouring health boards? So really just to give confidence that we are fully focused on it and have a plan being developed by Gethin and the operational team with ophthalmology colleagues to make sure that we've got the capacity to respond to that.
Thank you, Paul. Can I just again confirm, Wendy, are there any further questions or comments, please?
Nothing further, Chair.
Thank you. Thanks to Mel for the report. Unless there are any objections, I suggest the board resolves to note the report. I now propose that we take a break. The time now is 3 minutes past 11. If I could restart the meeting at 10 past 11, and could you switch your cameras and microphones off, please, during this break? Thank you. can I just confirm that everyone's back in the meeting, and if you could count me into the next part, please.
There you go.
Okay, welcome back from the break, everybody. Can I then move on to item number 6, please? And that is delivering our purpose and strategic direction. This report is before the board for noting and has been discussed at a number of forums, including most recently at the Executive Leadership Group. This report has also been scrutinised by our various board committees prior to it coming before the board. And I invite Linda Prosser to introduce the report, bringing in relevant executive leads to provide updates against their respective areas. Linda.
Thank you, Chair. So my role is to provide the overview and to talk about how the report is developing and changing. And members will note that the early charts on the report are developing, and then the Planning, Performance and Finance Committee has been really helpful in providing feedback to help us with develop those charts, and the little charts that are on the right hand side to help us understand at a glance where we're at in terms of the performance of against the targets. The narrative is in the further down sections on performance is also undergoing some review in terms of how the authoring of those narratives is developed, so that the board is brought more detail about current activities that are being undertaken and the impacts that those are expected to have. So I was I think I know that we're coming in later to talk about urgent care and the 6 goals programme, so we might not want to look at that in too much detail and save it for then. Ditto planned care, but I think there's obviously a range of indicators here. There may be specific questions, particularly on sort of up to page 9, where we've got some those charts where we're looking at where we are and aren't on trajectory. I wasn't going to pull out anything more specifically myself, Chair. Maybe open it up to questions.
Okay, I invite board members to raise any questions, and if I could invite James Sagrove in, please.
Thank you, Chair, and thank you, Linda. This section of the report is clearly developing, as you say, but isn't as yet a complete set of charts. I'm interested that some of the charts actually only have single data points, and I mean, one of them is on page 9, the staff engagement. Another one is the bowel screening chart, where we have one data point from 2019-20. Is this because further data is not available, or is it because we haven't as yet managed to get the mechanism to feed into the graphs?
On occasion, so for instance, the staff engagement, that's the results of the annual staff engagement survey, so that will only be a single year data point. I don't actually know the answer about the bowel screening data point, and I will take that back and find that out specifically, unless Kelechi knows the answer to that.
Okay, can I invite, sorry, does Kelechi want to respond to that point that Linda's just said about the bowel screening?
I am sorry, could because my my coffee kettle was late. Could you I just came to the very end of that. Could you just pose the question again, Linda?
So the question is on page 5 of the performance report. We have a single data point entry for the bowel screening programme and the percentage of people who have participated, and we don't know why we don't have more data.
I don't know the answer to that question, but I will. The Public Health Wales would have the answer, but I can look it up and come back if that's okay.
Thank you for that, Kelechi. Can I invite Howell wanted to make a comment in relation to the engagement data?
Yeah, thank you, Chair. So Jane, so you'll note that the engagement data is from 2020, and that's, I presume, why you'd, you know, when Linda said about an annual survey had reacted as you did. So I think there's something there about the NHS Wales staff survey. So the last NHS Wales staff survey was in 2020. We were anticipating thereafter an annual survey, but for reasons that are peculiar to HIW, who host the survey on an all Wales basis, that sadly hasn't happened. They are in the process of procuring a new system so that we can, as they do in NHS England, run an annual survey, and then we can run quarterly or periodic pulse surveys to sit alongside. There's been various reasons why that hasn't happened, linked to kind of false dawns in the national survey, where we've been kind of waiting for something that hasn't quite happened. So I expect that to land fairly soon. At the moment, that data isn't particularly meaningful, and if I'm honest, I'd probably pull it out of the next report and wait until such time as we get to a point where we've got regular data that we can compare. And then I would probably suggest that we take the engagement index questions in their entirety and report those into the performance report. So it's a point in time thing that will be resolved hopefully in due course.
Okay. Is that okay with you, Jane?
Yes, thank you. It probably would be worthwhile someone looking through the entirety of the report and picking out where data isn't coming in successive years, so that we get a better overall picture, because after all, this is meant to inform the board. Thank you.
Comment noted. Thank you, Jane. If I could invite Paul Mears in, please.
Yeah, just in a way to follow on from Jane's point, really. I think, as Linda said at the beginning, this is a report that's in development at the moment, and I think any feedback such as we've just had today, I think will be useful. I still think there is something about trying to sort of be really perhaps tighten up a bit about the sort of number of metrics that we're monitoring in this report, because there are a lot of things in this report, and as Jane just highlighted, there are things that only been measured annually. Then I wonder whether is it worth bringing? Do we need to review that every month? Some of those metrics may be more in a different type of report or a less regular reporting framework. But I think it'd be useful to perhaps get some thoughts, and perhaps it's a topic for a future board development session, really, about the volume of metrics, because we are measured in a lot of things as an organisation, as this report shows. And I guess the question is, how do we make it as relevant as possible for board members and highlight the exceptions so that actually the focus can be on the areas where we need to be focused, because I do have some concerns sometimes where there's such a volume of metrics being provided that we sort of lose the wood for the trees, or can't see the wood for the trees, and miss things. So perhaps we can pick up a conversation at a future board development session, really, about how we best present and a report that is useful for both the execs and independent members.
Thank you, Paul. I think that would be most helpful. Can I invite Ian Wells in, please?
Yeah, thanks, Emrys, and thanks, Linda. I think this report is great. I love the little graphs that you can see the trends over time and so on. And I think it's really going in the right direction. So I'm really happy with where you can see how things are developing. And so my question is sort of related to that development, really. And if this is coming up later, then maybe the question can be passed on for later on. But I'm looking particularly at the emergency response to red calls and the ambulance patient handovers in 1 hour. Now, I know an awful lot of work is going on in that area, and the board has had lots of discussions on that in the past. But if you look at the graphs, they are showing a deterioration over the last few months. My question really related to that is this something that is going to show improvement in months to come as our measures kick in? So I don't know, checking it out there.
But I think that my response to that would be that we will discuss in some more depth the 6 goals work, which is in part designed to improve this. I would make one observation. It doesn't take away the fact that we are still committed to fixing this, that the scenario that you're seeing there is repeated across all health boards in Wales and indeed in the UK. The pressures are within hospitals are well, and then within EDs are well documented. Our response actually in CTM is actually, you know, we're doing okay compared to some of our colleagues, but you know, I don't want us to feel that we're doing okay. But as I say, Gethin will say a bit more later about the measures that are being brought in, and the winter plan that we're presenting also overlaps with answering that question.
Okay, thanks.
Thank you, Ian. Thank you, Linda. If I can invite in Patsy Roseblade, please.
Thanks, Chair, and thanks, Linda. And also thanks for adding the trend lines and the trajectories. That's helpful to see which direction the graphs should be going in. So it draws our eyes to those that we need to focus in on. I've got quite a few questions, so if I go through them and then give colleagues the opportunity. On page 11, and this is an example of nationally and locally reportable incidents. There's 2 charts, and but the y-axis is different on both charts, so you think you can compare both of those. And I know one's local and one's national for the reportable incidents, but it would be really helpful if that y-axis were the same, so we could see the differences in those charts. I think that would be very helpful. And just still on that page, the number of patient safety incidents is very random. And where there are clusters, as we can see there are on the table on the right-hand side of that page, I wonder what work goes on to look at what was different and why that cluster of incidents occurred. So that's my first question. My second question goes down to page 20, and it's on the staffing. Do we know how many people or what percentage of staff have received the flu jab this year? Because I noticed the incidence of flu and cough and cold and everything is increasing. Another example on page 26 is where the SPC charts change. So the upper and lower limits change so that the data remains within the boundaries of the upper and lower limits. I see little point in doing that. I understand the boundaries will have changed post-COVID, but some of them change 4 or 5 times just to keep the data within the upper and lower control limits, and that's not really the purpose. The purpose is for us to see when we breach the upper and lower control limits of that SPC chart. So just something to look at really. And finally on page 33, I know there'll be a discussion on ambulance waits and handover, but in particular the red release information that's contained within this report makes very difficult reading, particularly in relation to POW. We have had an in-depth discussion and we'll have further in-depth discussions in the Q&S meetings, quality and safety meetings, and I'm sure Gethin will draw attention to that when we come on to the 6 goals and the updates later on. Thanks.
Shall I comment on or invite comment on the ones that I think we can comment on, Chair? So I think we can look into the incidence y-axis and whether we could represent that more commonly. Debbie may have some comments on the clusters of patient incidents and how those are identified and reviewed?
Chair, would you like me to come in now?
Yes, please, Debbie.
That's right. So, Patsy, we do have a weekly exec catch up with all our patient safety incidents, and we do look at those trends and deep dive into those. So, and we also look at the slight uptick. So we've always look at a 6-month average and to see whether our weekly data is going up or down, and there is a natural variation in there, but it's all within that 6-month average on the whole. Don't know whether that answers your question, or I can give you more detail on the exact detail and papers if you'd like that a higher level report at some point.
I just want to know that somebody's looking at those clusters where they change.
Absolutely, we've got the corporate team, Greg and myself, and medical director look at those. Yes.
Thank you.
So the next question was about flu jabs in staff, and Kelechi can come in on that one.
Thank you. I'll pass this question about flu jabs. So I can confirm that as of the 17th of November, when we actually downloaded the data, uptake of flu vaccination in healthcare workers was 42.6% in CTM. And that compares to the Welsh value of 32.8. So compared to Wales, it compares favorably. It's not really where we want it to be. We know that we've had some challenges in that respect. So we're working very hard at increasing the uptake, but at this point it's about 42% and higher than that of the Wales average.
Thank you. Patsy, we'll perhaps have a further conversation about how we use SPC charts. I think I've seen them used both ways. One is that shifting the control limits tells you that something has happened in the system, and it's that jump that you're looking for. But I understand that once you've got an established system, you are looking for events that exceed your control limits. So I think I think maybe this has been misused on this particular occasion. So I will talk to the team about that. And I think that, as we said before, I think we will ask Gethin to just talk about the red release as well when he does his section on 6 goals.
Thanks, Linda.
Thank you. I'm conscious as well that we're going to perhaps some of the detailed discussion of the agenda items around operating delivery performance and quality performance. And I suppose it might be helpful if, when we discuss those items, that some of those any other questions on those issues are raised through those agenda items. Can I just confirm, in relation to those who may want to ask questions of the report at the moment, are they happy that they're answered in respect of operational delivery performance and quality performance when it comes on the agenda items, or is there something specific you would like to ask now? And I think it's Nicola and Mel I've got down as wanting to ask questions. Nicola, you're on mute at the moment, sorry.
Sorry, thank you, Chair. My question isn't covered in any other papers, and it's in regards to page 4, and it's the people section. And it's in regards to our exit interviews, and it does seem as if we're not interested in hearing from people who leave the organisation. But there has been a lot of work looking at our exit interviews so that they're meaningful and easily accessible. And I just wondered whether somebody could just give an update, because I know there's a lot of work going on and there will be a relaunch.
Okay, if I can invite Howell in for that then, please.
Yeah, thank you, Chair. Thanks, Nicola. So you're absolutely right. So we've, my understanding is, so I know you and I spoke about this towards the tail end of last week. I asked for an update from my team this week. I understand we are relaunching the new exit process at the beginning of January. So I'll double check that with my team, but that was my understanding earlier on in the week. And you know, we've hopefully designed a process there that works for individuals leaving us, you know, rather than for us, and that will have a real impact then on our completion rates.
Thank you, Howard. Thank you, Chair.
Thank you. And if I just check with Mel as well, is that is your question, Mel, does it relate to an area that's outside of the next items from 6.12 to 6.15, please?
Yeah, it is outside that, Chair, and if I can ask this question, it's not relating to any of the figures that Linda's presented, it's about figures in general. I read last week that the Prime Minister, that the Chancellor and of course the Health Minister in the English UK are now going to put a project team together to look at the number of targets that the health service in the English NHS are having to be answerable to, and they're going to look at reducing some where some of the targets are not attributable to actually the impact on patient care, if I can put it that way. My general question, I'm sure if there were community members looking at this now, they'd be interested in this one. Is there any interest in the Welsh NHS at the top ministerial level that we're aware of to actually look at the issues about the number of targets that we have, perhaps to reduce bureaucracy where they don't actually have an impact on patient care at the front line? So I don't know if Paul or any more Linda can answer that question.
If I could invite Paul Mears in to make a comment, please. Paul?
Thank you, Emrys. My video stopped working, but I'll carry on talking. Yes, Mel, we had, in fact, Emrys and I yesterday were in a meeting with chairs and chief executives with the Minister, where she was talking about next year's priorities. And I think it was clear from her discussions yesterday that there are certain areas that she's very much focused on, which I think we need to make sure are top front and centre of our reporting, because that's clearly the things that government are going to be wanting to see us delivering and will be monitoring our performance against. I think there is a challenge with this, and there isn't a sort of a systematic approach being put forward by Welsh Government to reduce the numbers of targets. The challenge is with every one of these metrics, I think, you know, there's an absolute validity to all of those metrics that are included in the performance report. But as you rightly say, man, it's about monitoring what's the outcome been. And I think going back to Kelechi's population health agenda and things, we also should be monitoring as an organisation where we are in terms of wider health outcomes for our communities. Right, because a lot of these measures are input measures and they don't necessarily monitor outcomes. So there's something about how do we make sure we're doing the things we need to respond to for governmental performance management purposes. But there's no reason why we as an organisation couldn't perhaps think about outcome measures or community focused measures that we would want to track ourselves. And things like community engagement and things like that, I think, are a really important measure for us as an organisation about our ability to deliver our ambitions. So I think, going back to my earlier point, this would be quite an interesting conversation for a further debate as a board, because I think, you know, some of these things we have to report on, obviously, because we're measured on them, but there is some potential flexibility for us to look at how we can develop our own local metrics that are more responsive to our communities.
Thank you, Paul. Thank you, Chair.
Thank you, Mel. I think it's just noting Paul's last comment there, and supporting in that comment about we need to do a board development session around outcomes, systems measuring, and how we can improve our performance. How we measure outcomes from a health board perspective, and I think that's a positive way forward. Can I then go on to item 6.1.2, please, which is the operational delivery performance. And I invite Gethin Hughes to present the update, which is before the board for noting. Gethin.
Thank you, Chair. I'll update now, and as Linda's previously said, I won't talk significantly on unscheduled care nor on planned care, and we'll pick those up as the two separate papers. It is just worth, you know, our 4-hour performance for seeing and treating and discharging patients within our emergency departments did dip slightly in month from a sort of 64% position to 61%. It is worth noting in October we saw an additional 1,200 patients across our 3 emergency departments in the month, and we actually saw more patients within 4 hours than we had in the preceding months. but the capacity constraints of seeing that additional volume meant that a fewer number of our percentage dropped, although we did see a greater volume of patients in 4 hours in that time period. I will briefly touch on red release because I think it is such an important important challenge, and there are some, as has been discussed, excuse me, at in quality and safety, there's some very specific work going on across all of our hospitals, but specifically around improving the position at Princess of Wales. And we're bringing a detailed report back to quality and safety in January on all of those actions that are have been taken and will be taken, and as part of that change. But there are a number of initiatives that are kicking in during December, changing the as outlined in the paper, which we believe will have an impact on improving red release performance. But I do have to stress, the key driver to our inability to offload ambulances is about flow out with the A&E department, and as you'll see on page 37 of the report, we have a significant challenge within Cwm Taf Morgannwg with delays of patients leaving our hospitals. So we have a delayed discharge rate of 40% higher than other health boards in Wales, and there's been a paper published by the Health Foundation this week, which on the issue of ambulance handover delays, and that's very clear that the top priority in order to address ambulance handover delays is increased investment in social care and out of hospital capacity. So there is, and we will come on to the actions that we're taking around that. This it is absolutely vital that we're able to release ambulances in a timely way to support, and that has to be a key drive. We have a summit with the Minister on Monday on those subjects as well, looking at that across Wales. I'll just draw also your attention to cancer. As I've raised in previous board meetings, we would expect to see cancer performance deteriorate, and it certainly is at a level that we wouldn't want, but is reflective of the fact that we are dealing with the backlog of patients that have been waiting on cancer pathways. What we are seeing though is that volume of long waiting patients reduce. So we have seen a significant reduction in both the 104-day waits and particularly in our over 62-day waits as changes to pathways have now started. So particularly the introduction of the one-stop gynae clinic, suspected cancer gynae clinic at the Royal Glamorgan, where all patients from the Health Board are directed, has seen a significant improvement in our management of those patients. We have got a deep dive on cancer performance coming to the PPF committee in December, but absolutely remain on track to getting our performance back up to 70% by the year end, as previously set out. I will also pick up on a couple of mental health metrics, if I may. So adult mental health. So we are seeing reasonable performance in our adult mental health services, and remain above trajectory on a number of those key indicators. The area where we do need to see significant focus is on the access to therapy. We have recruited additional staff. There's a lot of work going on around the role of group therapy as part of that, so that we can provide more timely access to our patients. And CAMS, and as similarly to cancer, the priority within CAMS is to clear down the backlog of patients waiting, and there's been a significant focus on that as I've updated at previous boards. What we have seen is the positive impact of those changes, and the predicted compliance for October is at the moment at 49%. So we are seeing a significant improvement in that first stage of assessment for CAMS patients. The second level of focus now is very much on the care and treatment planning aspect, where we've picked up you know the caseload of that for that has increased significantly. And the other subject I'll just pick up briefly is around stroke, which I know is a key concern to all of us, is improving the performance of stroke care. We are seeing an improvement in terms of a single service for stroke across the health board. So we now have a single stroke physician on call, rather than the historic two different models across Princess of Wales and Prince Charles Hospital. And we now have a ring-fenced stroke access bed on both sites to ensure that we can get patients in a more timely way to the stroke units, where we know they get the best MDT and therapeutic support. I'll stop there, Chair, but happy to take any other questions on any of the key operational metrics.
Thank you for that, Gethin. I invite board members to raise any questions. If I could invite Linda Thomason, please.
Thank you, Chair, and thanks, Gethin, for that comprehensive update. I suppose without wishing to be too much of a doom monger, these numbers are quite sobering, particularly because big diseases affect large numbers of people and cohorts of the population. So a couple of questions really. I was wondering whether or not at a future meeting, and maybe this is one for you, Chair, as well, about could we have a bit more of a deep dive at full board level, really, around some of the perhaps the big disease areas. Looking at some of that. So I recognise that gets picked up at committee, but it might just be helpful for all of us to be able to understand that as well. And then looking at cancer specifically, you might expect me to have an interest in that. I'm just looking at, you know, when you mentioned about 70% numbers by year end, I'm just wondering if you think there's any possibility of Cwmtaf Morgannwg hitting that metric, and if not, when might we hit that metric? And then finally, I just had a question around. Clearly now, there's a huge issue here around the impact of the pandemic finally catching up with people coming forward. Are we seeing at Cwmtaf Morgannwg now more complex late diagnoses in cancer, which results in people coming in with stage 3 and stage 4, which is going to mean they're going to need a lot more care? And then consequently, do we have the resources to be able to cope with that extra number of people coming through? So it's just, there's a number of questions there, Gethin, and I accept that you may not be able to answer all of them on this call, and if not, I'm happy to take them offline if you prefer.
Thank you, Linda, and I know Paul wants to come in on the key disease deep dive, and I have to say Kelechi's presentation earlier this year on the presentation staging of our cancers within CTM is exceptionally sobering, recognising that historically our patients present later with disease than they do in other parts of Wales and the wider UK. So in terms of do I believe that we will hit 70%? We're absolutely doing everything we can to hit 70%, Linda. That is the priority, because this is about, and the vast majority of these patients don't have cancer. They've been referred with the suspicion of cancer by their GP, and it is only right that if we can either let them know that they don't have cancer and they can get on and live their lives, or if they have got cancer, we can provide them with treatment in a more timely way. There are a couple of areas of focus for us. So from an imaging perspective, we have seen our imaging performance really improve. So all our suspected cancer patients are now scanned within 2 weeks, and that's been a big effort in order to bring that down, to improve throughput through a range of our tumour sites. We have got an exciting development to move to a nurse-led head and neck biopsy service, and if we're successful in securing funds for that, that would be the first in the UK of that type of model to really speed up the diagnostic pathway for patients with head and neck tumours. The two areas that remain a biggest challenge for us are lower GI, and for urology. And so we're doing a lot of work around the urology pathway, expanding our diagnostic capacity, and we are seeing the improvements in that as we proceed. Lower GI is more of a challenge because we get a large proportion of our suspected bowel cancer patients come via bowel screening Wales, and they come to us very, very late in terms of their pathway. And then it is the challenge of getting those patients through a diagnostic colonoscopy and then onward treatment. So we're working very closely with Bowel Screening Wales to ensure those patients can come through in a more timely way, and so that we can get them through the endoscopy. But endoscopy capacity remains a really significant rate limiting step for us as a health board, and therefore lower GI is our biggest risk specialty. But in many other specialties we are seeing good and sustained improvement.
Thank you, Gethin. Thank you, Linda. Can I invite Paul Mears in, please?
Thanks, Emrys. Just on the point about Linda raised about the disease-specific things, I think that would be definitely something we could consider doing as part of the board briefing, and perhaps tying it in with some of the public health outcomes data, because I think in some of these diseases we've got some very poor outcomes in our community, so it'd be useful to be able to highlight what not just the sort of clinical dealing with the disease when it presents, but also how is our approach around population health prevention, trying to sort of stem the flow of growth in some of these diseases. I think also just to pick up Gethin's point there about some of the pathways, particularly cancers, but also some of the elective care pathways. Board members obviously will know that we are also exploring opportunities to create more capacity in terms of elective care and also diagnostics, working very closely with the National Endoscopy Programme and our partners at Cardiff and the Bevan Health boards, because we recognise our capacity in diagnostics is one of the limiting factors, particularly Gethin's highlighted their endoscopy. But I also just wanted to say, as Linda highlighted, in COVID has led to a more challenging position. But I think we should also remind ourselves we were not, CTM as an organisation, indeed the wider NHS in Wales, was in a pretty challenging place before COVID. So we're picking up a situation here that was already challenging, as now has been exacerbated by the pandemic. But I think the other really positive thing just to highlight is we've been having regular engagements now with the consultants and clinical teams around these areas, and there is a willingness and a drive for thinking differently about how we approach some of these challenges, which are quite long-standing. But I know Gethin's been leading lots of conversations with clinical teams about how we can also look at making best use of our collective resources, because as we know, part of our challenge is having 3 acute sites trying to do a bit of everything. That can often lead to lack of efficiency around capacity utilisation. So there's a lot of opportunities, even in the short term, as Gethin's outlined in some of these challenged areas, just by consolidating and bringing together clinicians from across sites, that we can start to sort of spread the workload, ensure that actually everybody across CTM, all the patients, are getting an equality of access, and that we're using our collective resources to the best effect.
Thank you, Paul. Wendy, can I confirm, are there any other questions, please?
Nothing further, Chair.
Thanks to colleagues for their contributions, and I suggest that unless there are any objections, the board resolves to note the report. Can I just also add as well, there's a number of comments and suggestions made through this particular agenda item and the previous one around data, outcomes, system measures and disease focus, which we'll take those points to see how we can progress those as well. Can I now move on to item 6.1.3, please, which is around quality performance. I invite Debbie Benyon, Sally Davis and Stephanie Muir to present their respective areas in relation to the update which is before the board for noting. Colleagues will know that this report has received scrutiny at the recent Quality and Safety Committee and will therefore encourage a focus on key areas for board awareness. If I could invite you in then, please.
Thank you very much. Would you like me to make a start? And
yes, please.
That's great, thank you. If I take you to the infection prevention and control section on page 9 and 18 of that report, just to note, headlines are that we've had fewer cases of Clostridium difficile and E. coli reported for this for period April to October 22 compared to last year, but we have had a slight uptick in our Staph aureus and Klebsiella. Just to note, there's a significant portion of our gram-negative bacteria, so those are like E. coli, Klebsiella, and they're community acquired. So our infection control teams are scoping what support they can now give by looking at their workforce slightly differently into support they can give to the primary care, linking in with GPs about their prescribing practices, and also care homes and community nursing teams in terms of catheter care and that type of thing. Moving on to page 12 of 52, again, that provides details of the Never events, which we've talked about, that we've had no Never events since July. And we've talked about the national reported incidents and locally reportable incidents. Just as a note, the locally reportable incidents, we have chosen to adopt that model so that we actually, the things that aren't reported as nationally reportable, but we feel as a health board need some further scrutiny investigation into, we're continuing to log those and follow them through in the same manner that we would investigate a nationally reportable incident. In relation to falls and pressure damage, that's on page 17, slight little uptake in falls and also pressure damage. Just as a note of caution with some of this data is our All Wales DATIC system. Currently, it grades at the initial reporter stage. So at the moment, we can't downgrade them. So what we're doing as a mitigation is all our community sites, teams and all our sites are having falls and scrutiny panels, falls and pressure also scrutiny panels for everything that's graded as a moderate or above, to be able to make sure that we are actually looking at these. Those that then need to go on for redress, etc., go on via that route. I'm going to stop there and pass on to Sally and Steph unless there's any questions.
Should we wait for questions at the end, Debbie?
That's fine, okay. Chair. That's absolutely fine, Chair.
Do you want me to go first, Sally? Okay. So in terms of complaints and compliments, you'll see we had 75 formal complaints in October. Our 30 working day response is slightly below the target that we would, the 75% target we would like. However, we are going through a period of change at the moment in line with a new operating model. We are realigning our complaints management process to a more central function. Those changes should be in place early 2023. There's going to be a real focus on working with our patients and publics on early resolutions rather than going through a more formal, lengthy process, so we can actually provide a better response rate to our patients and public. In terms of compliments, the Civica system is up and running and we're using the Civica system a lot more. It's in the process of being rolled out and we've had 80 compliments this month. We have the Have Your Say cards being rolled out across the health board, and work continues in this area. It's a very new system and we're working very hard now to capture patient feedback in a more timely manner.
Thank you, Stephanie. If I could invite Sally in then, please.
Thank you. If I could draw your attention to I think it's page 14 on medication incidence and mortality rates. Medication incidents, we've done a lot of work around that. It was a focus of a learning day very recently. We have a new chief pharmacist also in post who is going to reorganise some of her roles, which will also help in that area. We continue to monitor that closely and feedback to prescribers where there are themes. The vast majority of those incidents, I should say, result in no harm. But it is obviously something we are going to continue to work to improve. The mortality rates you can see appear to have increased towards the end of the period. Yes, I'm sure the board are aware that CTM have used the medical examiner model, which means that all in-hospital deaths are reviewed. Medical examiners are independent of the organisation, and the review goes through several stages. If there are concerns, those concerns are escalated, and we make sure that the right investigations and reviews are performed, and all that is done in conjunction with families, who are also asked whether they have concerns in care. And from those reviews we can see that 85% of those who died in hospital received good care, with only 0.5% having any significant concerns about care. I'd also point out that these are crude mortality rates, which don't take into account those on an end of life pathway, or indeed in a hospice, which is within the hospital. So those sorts of figures can also skew the results. So I think that's as much as I wanted to say, and happy to take questions.
Thank you, Sally. I invite board members to raise any questions for either Debbie, Stephanie or Sally, please.
Questions received.
Wendy, can you confirm if we've got any questions or comments for colleagues?
No questions received, Chair.
Okay. Well, thank you to colleagues for their contribution. Thank you to colleagues. I suggest that unless there are any objections, the board resolves to note this report. If I could then go on to item 6.1.4, please, which is workforce performance. I invite Howell Daniel to present the update, which is before the board for noting. Howell.
I suggest, Chair, that we take the next item and come back to Howell.
Okay. If I could then move on to 6.1.5, which is financial performance. I invite Sally May to present the update, which is before the board for approval. I would like to advise the board members that you made aware prior to the meeting they will be asked to approve the following. The board is requested to approve the application for strategic cash support from Welsh Government to cover the cash requirement resulting from the projected core plan deficit of 26.5 million. This would be applied for by an accountable officer letter to be submitted by the 8th of December 2022. It should be noted that there is a separate process with Welsh Government to request cash support to cover movement in working balances, such as release of annual leave accrual and other balance sheet movements. Mitigating actions will continue to be applied where possible to reduce our cash support requirements, including timely recovery of income, such as Welsh risk pool reimbursements. I invite Sally in, please.
Thank you for that, Emrys. Really helpful. In the interest of time, I'm just going to focus on a few key issues in the report. So we are maintaining our forecast core plan deficit, although noting that performance year to date is 1.7 worse than plan, and we're assuming that we release some of our annual leave accrual. Our forecast on exceptional costs has remained at 17.8 between the 2 months, and a slight decrease in COVID cost programme response to 30.5, but it's a marginal movement. The things to draw people's attention to that's changed between month 6 and month 7, month 6 having been reviewed in depth at PPF, is that all exceptional and COVID response costs we had previously had indications would be fully funded, but we're identifying that as a risk. They've now confirmed that the month 6 forecast for those 2 areas will be funded as the maximum level if we deliver a cost that's below that, we will have to return the funding. If it goes above, that is a risk to us. So that is a change in our risk around our core forecast. I think it's worth me drawing attention to that we've deteriorated our forecast recurrent deficit to 47.5 from 34.9 million the previous month. This represents the failure to deliver recurrent savings and some of the underlying cost pressures to coming through. But I have to also note that that doesn't include any recurrent impact of the COVID response costs that we're having funded separately, or the exceptional items, including energy, moving forward into the next financial year. The cash shortfall we've just dealt with is identified, and if board members are happy to approve the recommendation you just read through, Emrys, then that will allow us to submit our accountable officer letter and seek cash support for that deficit, which will be important in making sure we can meet all our obligations as we get to the year end. Just a final point, compliance with public sector payment policy has been below the 95%, largely due to delays in nurse agency invoices, which is a large number, but not so much of a large value at times. We've now gone to 93.9% on that in month, and that's because there's a new agency self-billing process, which we discussed in PPF, and it's started to show a significant improvement. So I think that's positive in that respect. So happy to take any questions, but that's the main issues.
Thank you, Sally. I invite board members to raise any questions, please. Wendy, can you confirm if there are any questions from the board, please? I've got one question coming here for Patsy Rosemary. Patsy?
Just a comment, really. I'm happy to support the request for cash. There is no alternative. That was inevitable throughout the year with a forecast deficit position. And to note, this report continues to be more informative and more understandable, I think, for members of the board. So thanks, Sally.
Thank you.
Thank you, Sally. Thank you, Patsy. Wendy, can you confirm if there are any further questions for this item, please?
There are no further questions, Chair.
Okay, can I say thanks to Sally for her report? I suggest that unless there are any objections, the board resolves to note the support and approve the application for strategic cash support from Welsh Government. I can note from the sidebar comments that we've got approval from the board in respect of this. Can I now go back on to item 6.1.4, which is workforce performance? I invite Howell Daniel to present the update, which is before the board for noting. Howell.
Thank you, Chair, and apologies, had a couple of connection issues there. So just a couple of things I wanted to highlight. So you'll note in particular the turnover statistics within the report this month. So we are seeing, following a national trend, and that is a Welsh trend and a UK trend, an increase in turnover across a number of our staff groups, mainly our additional clinical services staff group, which includes our HCAs as a cohort, but also in nursing and in medical. It's a complex picture, and there are a number of different reasons for that. So we are seeing continual reporting of the pensions issues for doctors, albeit we have recently, as an organisation, you'll be aware, approved the pension flexibilities. Thus far, we think we've received more applications for those flexibilities than any other organisation in Wales. And I think we should probably view that as a good thing, because if it enables us to retain experienced medical staff, then I think that is a good thing. We're also seeing a similar dynamic in nursing around retirements, but we are worryingly as well seeing quite an increase in turnover among the sort of 26 to 30 group. So we're currently doing some work on that just to try and understand what that is. Is it people jumping to take up promotional posts elsewhere, and what can we therefore do to create similar opportunities, which again is something we've discussed with trade union colleagues for some time, or is it something different to that that we need to be more concerned about and put in place? We know also that the vacancy position will of course have an impact across all of those groups. So the work that we're doing on workforce planning in nursing and medical in particular will hopefully over the coming months and beyond have an impact then on our headcount, which in turn will have an impact on turnover. So we have to keep an eye on that. Just in terms of sickness absence, we're still seeing higher rates of sickness absence than we traditionally would. We have not returned to pre-COVID sickness absence rates, and around 1.5% of our 7% or so sickness is still attributable to COVID. So we've still got some issues there, and that hasn't quite left us. And we're going to have to, I guess, learn to manage that dynamic in a slightly different way, and also makes our performance around return to work compliance all the more important. We are, however, seeing an uptick, a slight uptick in terms of trend on PDR, but also staff and man training and job planning compliance. So the trend and the trajectory there is upwards. We've just got to do a bit more work to increase the pace on those, because again, we know that performance discussions and PDR discussions will have a positive impact on retention and engagement levels. So that's probably all I wanted to highlight for now, Chair, and I'll leave it there and take any questions.
Thank you, Howell. I invite members of the board to ask any questions or any comments, please. Wendy, can you please confirm if there are any questions for this item, please?
Chair, I note that Nicola Milligan has asked Howell Daniel for further information regarding the age groups leaving, and that will be dealt with outside the meeting.
Okay, thank you, Wendy. And Howell, obviously you've noted that comment as well. Okay, thanks to Howell for presenting the update. I suggest that unless there are any objections, the board resolves to note this report. Thank you. Can I then move on to item 6.2, please, which is the capital programme mid-year position. And I invite Sally May to present the update, which is before the board for noting. Sally.
Again, I'll keep this brief, just some key issues out of this, which I think you'll agree is a very comprehensive report setting out a sort of extensive capital programme. So in terms of our discretionary capital programme, we have overcommitted that in that we've got more schemes than we have money. That's because we know that there'll be slippage in year. It is proving quite difficult at times to focus, to get responses to tenders as more firms are looking for work elsewhere potentially. So we've overcommitted, and we'll manage that back to the sum that we receive as we get towards the year end. We may see some additional funding, a slippage from Welsh Government capital being released later in the year. We've already seen something around emergency departments that we're expecting to spend around an additional £500,000. So there's work on that, and we have also reallocated in year. So for example, we have allocated a sum towards the fit out of Ward 16 at Princess of Wales, which is part of the surge plan, and we've done that sort of using slippage on schemes and allocation of our contingency. We're still holding some contingency around equipment, so should any large pieces of kit fail, we have sufficient capital to meet that. So it's which is the right thing to do as you manage it forward. Our All Wales capital programme at 55.4 million is very significant, and within that the PCH ground and first floor scheme is the most significant of those at 48.7 million. That is the single largest capital scheme in Wales at the moment, and as you probably board members are aware, we have a separate ground and first floor scheme board, which Mel J, who is the IM representative on that meets monthly to track progress on that scheme. So I think the thing just to flag is that there is always a risk of slippage as we move towards the year end, but we manage that very carefully, and we meet with Welsh Government colleagues through a capital review meeting on a regular basis and have regular touch points around how things are going. There is a potential for additional Welsh Government funding as we move to the year end. We've already considered what schemes we would put against that and what our priorities would be if that's available. And then just to flag, future capital availability as we move into next year and beyond also remains a challenge that we'll need to meet as we try to make service changes and improvements to our infrastructure. Happy to take questions.
Thank you, Sally. I invite board members to raise any questions, and if I could invite as the first questioner, Patsy Rosegrove, please.
Yeah, just to say, having spent 48% of the capital allocation, and in particular because of the huge PCH scheme, is really to be congratulated. I mean, that's a huge achievement, and that isn't often the case across Wales or indeed any health organisation with regards to capital spending. And just for information really for fellow board members, the audit committee, of which I'm the chair, continues to get very positive audit reports for relating to the PCH scheme. So just wanted to make colleagues aware of that. Thanks.
Thank you.
Thank you, Patsy. If I could invite in Ian Wells, please.
Yeah, thanks, Emrys, and thanks, Sally. Very detailed report, I think. I've got a couple of questions related to it. The first one is about the Sunnyside Wellness Centre in Bridgend. That seems to have stalled due to a contractor being appointed. The knock-on effect, which you mentioned in the report, of course, the two clinics now are having problems as a result of that. I was wondering where we are with the appointment of that contractor. It seems to be taking a long time for a new contractor to come into place. So that was the first question. Do you want to do that one and I ask the second one?
I do that one first because my memory might go.
Right.
So we're not the lead partner in terms of Sunnyside, Link are. So they're working through their processes in terms of an appointment of contractor. There have been a few issues as they've moved that forward, so it's not off the agenda. They are moving it forward, but it reflects some of the difficulties in the market, and there's a fragility, isn't there, in the sort of construction market, and it's a project that's already started. Not so much for the health elements of it, but for some of the others, which presents difficulties in then onboarding a new contractor and how you manage that risk. So I think we're starting to see some positive movements in that direction, but it is a complex area, but we're doing everything we can to move it along.
Okay, thanks for that. And the second issue was the theatres in Princess of Wales Hospital, due to the fire reports and so on. In the report, it talks about 5 different options that have been looked at, but there seems to be an endless number of committees that are considering it, and then it's gone on to the next one, the next one, and the next one. Seems to be taking a long time. That's the impression I get from reading the report. Are we seeing light at the end of the tunnel in terms of a decision as to which of the options they're going to go for?
I think I might ask Linda to comment on that, as she's SROing that particular scheme. She's appeared as if by magic. But in overall terms, one of our problems was that we had a sort of favoured scheme, but the cost of that scheme was far in excess of what was estimated by Welsh Government, and so we've been asked to go back round and consider a range of options, but I'll ask Linda to come in.
Right.
Yeah, so I wouldn't say it's the constraint is the number of committees that are considering it. I'd say the constraint is that we have perhaps an alternative proposal on the table which would supersede all of these. And so that's the time limiting step right now. And we hope that we will be able to be in a position to resolve this early in the new year in terms of our preferred plan.
Great, excellent. Thanks for that. Thanks both.
Thank you, Ian. Thank you, Linda. Thank you, Sally. Wendy, can you also, I've got another question here, please, from Mel Jehu, please. Mel.
Yeah, thank you, Chair. It's not a question, Emrys. It's just to support Sally. As Sally has indicated, that I sit on the project group and have done for nearly the last 7 years. But reading the report, and there's some brilliant work that's gone on, you know, and it's commendable the way that everybody's conducted themselves and the work that's gone on and involved in the financial management of this project. But nothing beats actually doing a walk around to see what's going on. And I know last week, and I have mentioned you privately and some other IMs, I, along with the leaders here, Bill Rogers, Jeremy Hollyfield, the members of Tilbury Douglas, took both the leader, the mayor, the deputy leader, and some dignitaries from Merthyr around, and they were just blown away. And you actually got to see this going. I know Jane mentioned the other day about the robot that we have to sort out all the prescription drugs. It's unbelievable. So the offer is there, and I spoke to Bill Sally about this and Jeremy yesterday. If any of the IMs would like, when perhaps the weather improves, perhaps we could arrange a meeting up on site and have one of our board meetings or an IM get together with some of the execs, and then we go and see it, because nothing beats that walk around to actually see where this money is going and the impact that this construction and this refurb of making up a new hospital in Prince Charles is going to mean to this health board in the future. So again, if IMs and through yourself, Chair, wish to do that, I'm certainly can be the conduit, I'm sure with Sally, into making that happen.
Thank you, Mel. And just to confirm further to the discussion of the IM meeting earlier this week, I've already taken this up with colleagues to seek the appropriate time when we can do that. So we're hopefully going to be able to do it in the new year. So thank you. I just check again then with Wendy. Are there any other questions or comments, please?
Nothing further, Chair.
Okay, thank you. Thanks to Sally for presenting this update. I suggest that this, unless there are any objections, the board resolves to note this report. Can I then go on to item 7, please, delivering our recovery improvement plans, and 7.1, which is improving urgent care. I invite Gethin Hughes to share the report with members, which is before the board for noting. Gethin.
Thank you, Chair. I won't speak at length on the report. It's in there. I'll just draw the board's attention to sort of 4 key areas, if I may. The first is the you know, as we've discussed, we've got 4 sort of key focus and work streams within this programme, and the priority actions for us during this period. One is the launch of our navigation hub, and that is about bringing together the work of our discharge teams and those of the local authorities into a single service that will be underpinned by the rollout of our electronic whiteboards across all 3 of our hospitals. So there's immediate a live update of the status of all of our patients, so that we're clear where they are in terms of their process, and secondly, linked to that is the introduction of an automated electronic referral for patients that are being referred on to other agencies for their discharge planning. So that is due to go live now early in December, and hopefully will significantly help us on the coordination of discharging our patients. The second piece is around rolling out the standard offer across the health board of same-day emergency care. We have a very mature model of medical same-day emergency care at the Royal Glamorgan, rolling out that model across both Princess of Wales and Prince Charles. Same-day emergency care for surgery, again building on the work of ASU at Princess of Wales, so that we have a standard approach. We're expanding that now to include gynecology, urology emergencies across the health board. So that continues to work exceptionally well. The final piece, and this I touched on this when we were talking about ambulance delays just now, is having a single process. So at the moment, each hospital has different processes for capacity for offloading ambulances, and we're moving to a single standardised approach across the health board. One of the challenges is, of course, we need to offload ambulances in a timely way, but we have very sick, unwell patients also present via our waiting rooms, and so it's really important that we have trolleys where we can immediately admit someone to if they present with a heart attack, with a stroke, not via the ambulance service. So those are the sort of the 3 key programs of work within 6 goals that we're delivering on at the moment. The final element of the paper, which we will touch on later on the agenda, is then the additional winter capacity, so that we are increasing capacity at bed capacity, but also the capacity at the front door to support the management of our emergency patients in that way. But I won't say any more, but happy to take any questions on that.
Thank you, Gethin. I invite board members to raise any questions, please. Wendy, can you confirm if there are any questions or comments, please?
Nothing further, Chair.
Okay. Thanks to Gethin for his report. Unless there are any objections, I suggest the board resolves to note this report. I then go on to item 7.2, please, which is planned care recovery. I invite Gethin Hughes to share the report with members, which is before the board for noting. Gethin.
Thank you, Chair, and again, I think the report is self-explanatory. You know, and we've discussed at length the challenges of elective recovery within the health board post COVID. The key things to just make board aware: the primary focus that we are aiming to deliver is a reduction of anyone waiting over 104 weeks for a first outpatient appointment. And certainly by the end of December, we are confident that we will be able to deliver that across all specialties bar 4, and the 4 being ophthalmology, ENT, dermatology, ENT, ophthalmology, and urology. What we have developed, though, are plans where we will aim to deliver eradication of 104-week waits for first outpatient appointments in all of those specialties by the end of March 2023. So next March. So they are the sort of the key priorities. We touched on ophthalmology, and just in terms of detail there, we are working closely with Cardiff and AB. So we have instigated what we're calling Super Saturday. So we have a number of our clinical teams working at weekends, particularly on a Saturday, where we are treating the vast majority of patients. We also have secured capacity for 400 to 500 of our patients to be treated through the Vanguard Theatre which is based in Cardiff, and we are also working with an independent provider to look at some additional capacity for cataract work. But our focus remains very clearly on the eradication of those long waiters, and also then the follow-up cohort, so very specific action. So our Super Saturdays not only address capacity for new patients, our Super Saturdays are also about creating capacity to bring down our long follow-ups, and I'm pleased to report that the vast majority of the longest cohort of those has reduced very significantly, and we're aiming to get down to a sort of 1-year wait for follow-ups not booked by Christmas. So that remains a key focus of part of addressing the concerns that we were discussing at previous committees, but happy to take any further questions on those.
Thank you, Gethin. I invite board members to raise any questions, please, or comments. Wendy, can you confirm to me whether there are any questions or comments, please?
Nothing further, Chair.
Thanks again to Gethin. Unless there are any objections, I suggest the board resolves to note this update. Before I go on to the next agenda item, can I just propose that we take a 5-minute break, and we come back at 12:24, and we come back at 12:30 to recommence the meeting again, please. And the next item will be 7.3, which is the Regional South East Wales Work in Progress report. Okay, if you could switch your cameras and microphones off, and we'll restart the meeting again at 12:30. Thank you. Okay, just to confirm, if we could recommence the meeting, please. I notice we've still got the "we are taking a short break" slide up on the screen. Okay, thank you. Can I just confirm, welcome back everybody to the meeting. And if I could move on to item 7.3, please, which is the Regional South East Wales working. And then I invite Linda Prosser to share the report with members just before the board for noting.
Thank you, Chair. So members will have heard this reference to by both Paul and Gethin earlier in the meeting. This is the purpose of this report is to formally report to the board on this programme and to share its governance. Essentially, this is a commitment between Cardiff and Vale, AB and ourselves to make best use of resources where collaboration is going to give us more efficiency and effectiveness. You'll see in 1.3 the principles that are being applied across the region to ensure that we do drive best results for our patients, and then also in 1.5 the governance that's being established within the programme. But you'll also note that each organisation's undertaking remains to report on plans and changes to plans to its own board. I think that you'll see that the three areas of priority for us at the moment, you'll recognise ophthalmology, we've spoken about that a lot, and there are some opportunities here to improve our capacity across the region as we work together. The orthopaedics programme, for similar reasons, very high volume, is a priority. I'd say that one's slightly slower getting off the ground. The diagnostics programme is the one that we lead on, and actually essentially it's three separate programmes. So we're in the process of establishing the programme structures and appointing lead individual managers and clinicians. And in fact, there's a workshop planned for Monday with those individuals to start to put some flesh on the bones in terms of activities and plans. And as those become more specific, we'll be bringing those plans back here. But this is for the board to note that some of the plans that we start to bring will start to look a bit different as we introduce a regional element. So I think happy to pause there, Chair, and see if there's any questions.
Thank you, Linda. I invite board members to raise any questions, please. Wendy, can you confirm if there are any questions there, please?
Yes, Chair, we have a question from Patsy Roseblade.
Okay, can I invite Patsy Roseblade in, please?
Thanks, Chair. Thanks, Linda. Just a very quick question. What about residents of Powys whom both CTM and AB commission activity from? Are they covered within this scheme?
So within the chart on page 3, there's there's an oversight board which is just at chief exec level, which hasn't included Powys, but there's a steering group which sits below that where Powys are involved for the purposes, as you say, of identifying shifts in flow patterns that would affect their patients. And the Ambulance Trust is also involved at that level.
Thanks, Linda.
Wendy, can I confirm if there are any other questions or comments, please?
There are none, Chair.
Okay. Thanks again to Linda. Unless there are any objections, I suggest the board resolves to note this update. I can go on to the next item, please, which is 7.4, which is the integrated medium-term planning for 2023 to 2024. I invite Linda Prosser to share the report with members, which is before the board for noting. Linda.
So I think this can be fairly brief, Chair, because this simply sets out the process that and the requirements as we understand them so far around the IMTP. As you know, it's a statutory process, and we have various templates, and we still haven't received the guidance document, but there will be a guidance document that sets out the required activities and achievements from the plan. We have included in this document the financial background, the backdrop for this planning round. Extremely challenging, as you can see, looking at a gap of between 94 and 114 million pounds to be addressed. Our approach is very much working with the care groups to help them to look at their model of care and arrive at ways of working which help them to reduce costs whilst also improving services and working towards achievement of targets. There is one update since this was submitted, which is that we have now been given a reprieve by Welsh Government that our final board signed report is to be submitted on the 31st of March. However, we're planning on putting in an additional board meeting to review the plan at the end of January, so that we've got a bit of time for the board to understand where we've got to and what the next steps will be in preparation for that March board meeting.
Okay, thank you, Linda. Can I invite Paul Mears in for comment, please?
Just to say that Emrys and I were at the ministerial meeting yesterday with other chairs and chief executives, and the minister mentioned about the IMTP process for next year and her ambition that it's a more straightforward and simple process, which I think would be welcomed. Also, that there'll be a smaller number of things to focus on, and that there'll be a standardised template, a more simpler standardised template, partly to enable greater sort of consistency of plans across health boards, but also with explicit ambitions that we describe how we're going to respond to the particular ministerial priorities next year. So I think, you know, in some ways the simplification of the process, I think, is to be welcomed. But as Liz highlighted, there are still some significant challenges, particularly around the ambitions we want to achieve alongside the financial pressures that we'll be facing. So I think there will be a need for us to think quite radically about how we look at the plan for next year and focus our efforts on the things that are going to be prioritised, which unfortunately will mean there are other areas that may not be as high priority, which will require us to perhaps make differentiated decisions about how we use resources. But I think, as Linda's highlighted, there'll be plenty of opportunities over the coming months to flag that and share with board members how those conversations progress.
Thank you, Paul, for your comment. If I invite board members to raise any questions, I'd like to invite Jane Saggrove in, please.
Thank you, Chair, and thank you, Paul and Linda. Helpful clarification around the timetable, which actually helps address what I'm about to ask. In the draft timetable on page 5, it indicates that during December, the executive team and committee would appraise the draft. I was struggling to see actually how all the committees would do that, since quality and safety and population health and partnerships don't actually meet in December, and in fact don't meet until the end of January, beginning of February. And clearly we want, obviously, to take into account the financial issues and the performance issues, but it's also important for us as a board to take into account the quality and safety issues within our plan going forward. It's something we've been asked to focus on in the past, and just need to make sure that we get ample opportunity to make sure that those elements are considered in the IMTP as it is developed. But it sounds as if we'll have an opportunity to do that.
Thank you, Jane. And it may be that we will we'll have a meeting at the end of January, and it may be that other elements get strengthened through their committees subsequently. The important thing is that we bring it all back together towards the end of February to then develop the final plan by mid-March for the March board. So I think we do have time to do all of that, as long as we pull together a first draft by mid-January. And the timetable at the moment is that the care groups are coming back to us with their first cuts by mid-December. So it's with them at the moment. Then we'll do another iteration, which we can bring in mid-January, and then there'll be that opportunity to influence.
Lovely, thank you very much. That's really helpful.
If I could invite in Patsy Roseberry, please.
Yeah, thanks, Linda. Just quickly, given this year we were requested to send in an annual plan because of our financial position, the financial position for the 3 years and the duty to break even over that 3 years cannot be met as described in this paper, and completely understand that. Are we likely therefore to be requested just to submit an annual plan as we were this year, or do you think that they will continue to suggest it needs to be a 3-year plan, even though the likelihood of breaking even after that 3 years is remote?
So I mean, I think there's a good chance that will happen, but we don't yet know what Welsh Government's approach to non-balanced plans will be. In fact, so we'll what we do know, of course, is that we are in enhanced monitoring for being in our current financial position. But I think statutorily they can't accept an IMTP that doesn't balance, so there has to be a different nomenclature.
Yeah, okay, it just remains to be seen then.
Okay, thank you. Can I confirm with you, Wendy, are there any further questions or comments, please?
Nothing, Chair. Thank
you. Thanks again to Linda. Unless there are any objections, I suggest the board resolve to note this update. I can go to item 7.5 then, please, which is the Integrated Medium-Term Plan Annual Plan Quarterly Update. I invite Linda Prosser to share the report with members, which is before the board for noting. Linda.
So again, we do a quarterly update on our current plan, as Patsy says, now known as the annual plan. And previously we've referenced the work on the weight management, which was the one kind of discretionary investment that we were able to make for this year, because most of the rest of what we talk about relates to the performance that is obviously has formed most of the meeting. But what's different about this one is that we have now got these 7 additional updates on specific programmes that Welsh Government has asked for in relation to our annual plan. I wasn't going to go through them, Chair. They're all there for information. Mostly good progress, and some of them have been referenced elsewhere in the meeting as well. So we thought the board would like to see the positive progress in some of these areas.
Thank you, Linda. I invite board members to raise any questions or comments, please. Are there any questions or comments?
There are none, Chair.
Okay, thank you, Wendy. Thanks again to Linda. Unless there are any objections, I suggest the board resolves to note this update. Can I then go on to item 7.6, please, which is the winter plan update. I invite Linda Prosser to share the report with members, which is before the board for approval. Linda.
So again, at risk of repetition, the content of this paper has been covered to a large extent in terms of the 6 goals work and urgent care work, but just wanted the board to note that the winter plan also includes some activities around vaccinations. We've touched on that a bit earlier, and also the communication. So we do have plans around both of those. But we did brief the board in September. We briefed the board about our winter plan in terms of where we'd got to include how we were going to make best use of the resources we've got and to enhance flow, plus vaccinations and communication. So I wasn't going to repeat those. But what's new in this plan is that subsequently we have managed to identify £1.7 million for investment in additional activity. There's another 500,000 in there, which is from a specific grant from Welsh Government around 6 goals to be spent on the same-day emergency care service. But the reason this is brought to the board is for you to see a change in financial allocation towards these additional schemes, 3 of which you'll see are around bedded capacity. So that's at YGT, Princess of Wales, Ward 16, and Brocastle Care Home in Bridgend. So it's one in each, a facility in each patch, some additional beds being created there. And then the nearly £1 million worth of additional service activity in and around the hospitals to improve flow. So this is a change of resourcing, and we are asking that these changes are ratified and approved.
Thank you, Linda. I invite board members to raise any questions.
There are none, Chair.
Thank you very much, Wendy. Thanks again to Linda. Unless there are any objections, I suggest the board resolves to approve this report. Can I then go on to item 8, please, which is the escalation status, special measures and targeted intervention. I go on to 8.1, maternity and neonatal services improvement programme. I invite Suzanne Hardiker and Sally Davis to present the report, which is before the board for noting. We recognise that this report has been subject to discussion and scrutiny at a number of forums, including most recently at the Quality and Safety Committee, and therefore will focus on the key issues for board awareness. I can invite Suzanne and Sally, please.
Thank you, Chair. Sally, shall I start? Thank you. Since the papers have been submitted for board scrutiny today, we have received the 7th progress report and the publication from IMSOP, which recommended that we de-escalate from special measures, which was really pleasing. In response to this, we held a staff briefing event, which was very well attended and very welcomed by our staff. The key points for noting today is that we are still working through the remaining immediate escalations, having made some changes within the neonatal and maternity programme team to become more clinically driven. By doing this, the clinical improvement lead is able to test that change and make sure it's being embedded and becoming sustainable. The maternity dashboard has finally been launched. It's a great tool. There's been some training opportunities for staff to understand where it's hosted, how to access and how to use it, and opportunities for scrutinising and challenging at various quality and safety governance and audit forums is now in place. Data is also used to inform service improvements, as noted within the papers today. We are now very much becoming a data-driven organisation, and we're using the data from the dashboard to inform our continuous improvement journey by bringing in our PREM patient experience data as well, which is really pleasing. Obviously, our neonatal dashboard is still a work in progress, but we're working closely with our informatics team to try and align maternity and neonatal dashboard and make sure that our neonatal dashboard data collection isn't onerous on clinical time, but that's going to take some work. Interestingly, we had some information through this week from HEIW and Digital Maternity Cymru, offering an opportunity for neonatal colleagues to be part of a training fellowship to work with DCHW to scope and complete a neonatal service integration discovery project as part of the maternity and neonatal safety support programme. So we are very much involved in both nationally and locally driven improvements. Our quality improvement training is well underway. We have several projects now in the pipeline, all staff and data driven, which is great because we've come at this with a very bottom-up approach. We are progressing well against our 30-day targets for concerns. We have an extra layer of scrutiny in the responses, so they all come to me as Director of Midwifery for review before final sign-off. The IMSOP panel were also reassured by the quality of the responses and the timing of them that were going out.
Training for key mandatory and statutory prompt and CTG is on track. We did have a little bit of a blip a few months ago because of some staffing challenges, but we have recovered. In terms of safe staffing, we do have some challenges ongoing, but no different to anywhere else throughout the midwifery workforce in Wales. Most of our streamlined Band 5 students are now in post, with a few yet to start in the new year. And we are out to advert for some Band 6 vacancies with a rolling bank advert as well to try and attract some new midwives into the organisation. Human factors training is being incorporated into clinical supervision for midwives. So we've extended these opportunities to our neonatal nurses and our neonatal teams, which has been very welcome, and that seems to be going well. And the extended nurse rotation for our neonatal teams is now being offered to staff to attend Cardiff, Aneurin Bevan and Swansea Bay in terms of their development. So those are the key highlights from me, Chair. Thank you.
Thank you, Suzanne. If I could invite Sally in, please.
I don't think I have too much more to add to that, except to say that the 4 remaining immediate escalations that need verification, we're on course to deliver those in the next few months, and there's a robust plan to deliver them. But no, otherwise, I think Suzanne covered the essential highlights.
Okay, I invite board members to raise any questions, and if I could invite Jane Sadgrove in, please.
Thank you, Chair, and thank you, Suzanne and Sally. As members are aware, I attend the Maternity and Neonatal Improvement Board as part of our assurance chain, and I did so this week. And just to reinforce what Suzanne has reported around the dashboard, the dashboard presented there provoked a really vigorous and considered discussion around how the services could continue to improve and where their focus needed to be. So it's actively informing development of practice. And also there was a strong focus on the outstanding neonatal improvement areas with, again, a rigorous discussion on how actually we are going to gain assurance that the conditions have been met. I will continue, of course, to represent the board in those processes. Thank you.
Thank you, Jane. Wendy, can I confirm, are there any other questions or comments, please?
There's nothing further, Chair.
Okay, thank you, Wendy. Thanks to both Suzanne and Sally for the report. Unless there are any objections, I suggest the board resolves to note this report. Thank you. Okay, if I could move on to agenda item number 9, please, which is any other business. I've not been notified of any other business items. Wendy, can you please confirm if anyone has raised any issues under any other business?
No, Chair, I'm not aware of any other business.
Okay, thank you, Wendy. If I can go on to 9.1 about how we did in this meeting, and you remember at the beginning of the meeting, I referred to comments regarding this item made during your introductory and my introductory remarks at the beginning of the meeting, which I asked you to bear in mind. I therefore invite board colleagues to put forward any comments for improvement at this point or within 2 weeks of this meeting. So does anybody has got any suggestions or ideas or points they'd like to make about the board meeting today, please let me know now, or you can let me know within a fortnight. Well, Wendy, can you confirm if there are any issues or comments raised, please?
Nothing further, Chair.
Okay, thank you, Wendy. I go into item 10, the date and time of the next meeting. The next scheduled meeting of the board held in public will take place on the Thursday, the 26th of January 2023, commencing at 10 o'clock. I just go on to the close of the meeting. Rydw i'n dod â cyfarfod o bwrdd iechyd I ben a hoffwn I ddiolch I bawb sydd wedi ymuno a ni a gwylio cyfarfod heddiw. I now bring the board meeting to a close and would like to extend thanks to all who have participated in the meeting and or observed proceedings today. Please note that we will now be holding an in-committee session where we are being asked to discuss core participant status for Module 3 of the COVID-19 inquiry and the outcome of this meeting will be presented to the board at this next public meeting on the 26th of January 2023. So for confirmation, the meeting is now closed.